have another episode of Enhanced Physician Engagement. And so far, I have been interviewing my co-authors, and I'm very proud to interview Dr. Kevin Post here today. Now, physician engagement is a very, very hot topic right now because it's directly related to physician well-being, it's related to physician retention, it's related to physician turnover. So it's all like a big, neat package, and one doesn't exist without the other. And at the root of everything is physician engagement. And as you already know, we have this two-volume mega resource for you. Each one of the chapters is like a book in itself. And Dr. Post has written the chapter on telehealth and physician engagement, and you'll see how beautifully written the chapter is. Dr. Post is Chief Medical Officer at Avera Healthcare Systems in South Dakota. He's a family physician by practice, by specialty. And welcome, Dr. Post.
Good morning, and thanks for having me.
Okay, wonderful, wonderful. Your chapter is so close to my heart. I have been practicing telemedicine since 2006. So, and like you say in the chapter that, it's something that was so long overdue that people realize the value of telemedicine. You tell me about your chapter in the book. Tell us, why your writing would appeal to any healthcare leader who wants engagement from their physicians.
Yeah, thank you. So, my chapter on telehealth, and I'll share later maybe a story of why I'm so passionate about this topic of telehealth and physician engagement. But really, as I think about physician engagement, I do want to thank all of my colleagues, and I want to thank Carson Dye, Dr. Singh. I actually give a presentation this week for an internal physician development program on the topic of engagement. So, all of the collective wisdom of the group I'm bringing forward to many of our Avera physicians this week. So. I think as I wrote on the topic on telehealth, I think first I really wanted to start out with the importance of the why behind why we need physician engagement for telehealth to be successful, whether that's the integration of technology into the patient-physician relationship, the adoption of by the clinicians to kind of rise to the challenge that really I think came to the forefront during the pandemic. But as we mentioned, we're always there before. And then how do we leverage technology in areas of the country where there are geographical challenges? Because regardless of your zip code, your social determinants of health really believe that telehealth is a great tool we can leverage to kind of help balance some of them challenges. And then, as many things, as go the physicians, so goes the effort. When it comes to telehealth, if you do not have physician buy-in, physician support, I really think it can affect the impact and the success of telehealth efforts.
So what inspired you to write this? Tell us that story that made you
Yeah,
write this.
yeah. So I was as Dr. Singh mentioned, I was a rural family physician in Northwest Iowa for 12 years prior to being in this role. And I clearly remember one of my earliest probably endeavors into it. I would call telehealth today, although it wasn't that developed, but we did full scope care, including obstetrics, and I had a very difficult delivery where we had an emergent obstetrical condition that developed. And we moved the patient quickly from the delivery room into the operating room. In this setting, the general surgeon was in the operating room with me to help assist, but on early cell phone technology with video, and there might have been some privacy and security issues as we look back, but we actually had, with our cell phone technology at that time, we had a perinatologist,
Okay.
we had a neonatologist, and we also had a pediatric critical care physician as well as an obstetrician over about an hour and a half away giving us advice as well. So really what was amazing about it, within the small rural setting of a town of 2,500 people, we had 4 subspecialists on via telehealth. And that really made me see, wow, this is a concept that needs to be taken forward, because we can really provide a great quality of care regardless of where our patient's at, and support our rural physicians who often feel very isolated. It gives them access to the needs of our specialists.
Very nice. Very nice. No, I work very closely with all the people who are primary care specialists, especially I'm child psychiatrist, so pediatricians and family physicians. It's so much fun to work and even prevent a lot of specialist visits just by helping a primary care specialist that way.
Yeah.
So at this point, I when I read your chapter, and I want everyone to read this, telemedicine, in my opinion, is at a point where we are even giving terminology to things. Terminology hasn't been standardized. Your chapter does that. So for example, the way you describe this diagram, and I want to show this diagram to people. Let me share my screen and you'll know this one. Hold on. This one, the three virtual care components that you describe. This is standardization of terminology, in my opinion, that you have done. This is a much bigger service to the profession than just plain even physician engagement. Tell us about these three.
Yeah, I think, and these three are really core to what is overall virtual care. So when you think of that, I might start initially with telemedicine. Avera Health was very early on into telemedicine with what was called our e-care services. We were actually able to bring our emergency room physicians, then our critical care specialists into the room within rural settings within the Avera Health footprint, but also throughout many other health systems as well. So leveraging just telemedicine support. So that more maybe a little bit more high level. And then as we moved into more portal visits and virtual visits, it's really brought it closer to the individual patient. I think what's important to remember with our virtual care is always why we are getting into this. And to me, it's delivering quality care, safe care to our patients while supporting our rural providers. So when you think of virtual visits, what patient types can we see virtually and still maintain quality and safety outcomes? So when it comes to that, we have really taken an approach of focus where it fits. So as we mentioned, Dr. saying behavioral health is a great point of where we focus where it fits. Infectious disease has been another venue for us,
Mhm.
urgent care visits, and then any type of care coordination as well, where the visit may have more of an assessment component or of a counseling component. We really have found a lot of benefit. But regardless, even outside of that, with the new technology, leveraging technology that where you can do a very accurate virtual physical exam, that also has allowed us to do a wide variety of virtual visits. And then I think portal visits is so key because, traditionally in medicine, we have had more of an episodic relationship with our patients.
Mhm.
They come in for a visit, we see them again in 3 to 6 months, but often we don't have much contact with them in between. I think the portal visits has really given us an opportunity to have more of a longitudinal relationship with our patients, so we
Mhm.
can have ongoing touch points where they have access to our medical expertise and our recommendations. They can give us real-time feedback of what's going well, what their challenges are, what are their barriers that we can help remove. So more of a constant communication relationship with our patients has been key in the portal visits as well.
I love this terminology, portal visits, which should be standardized. It should be said just like how you describe it. It's wonderful. And I'm thinking like, in your opinion, what's the best way to apply this or use this?
I think to me, I believe you need to create buy-in from your key stakeholders. And
Okay.
by that is the key stakeholders, I would first put the patient at the center of that, but also your physicians, your best practice professionals, and really all of your care teams of how do you create buy-in? So by that, I mean going to the front line and saying what works for this. How do we give you the proper technology? How do we give you education so that you feel comfortable? You don't have any fear of using it, because often, when we don't have clarity on something, or it's not detail out of how you specifically use it, people tend to avoid it because we don't understand it. So if we can increase understanding on our patient side, on our clinical side, on our care teams, I believe that's the key to adoption. And then really going to the front line and saying what's working well, what isn't, how can we help improve and support this? I think other measures, of course, always maintaining quality and safety, even giving our care teams education on practice style over telehealth. It's a different type of interaction than it is when you're in the room with a patient. Many things carry over, but there's other small techniques that you can do to help be successful. So how do you educate on that? And then always maintaining patient health information, privacy and security are key as well. And then from an organizational standpoint and an operational standpoint, you can't overlook the revenue impact as
Mhm.
well. So how do you get fairly reimbursed for the care that you do?
What role do you see of the website presence that you talk about in the chapter?
And so I think for the website presence, it's more education for the patients so they
Okay.
know what type of visits, what it is. We have to I think we can never assume that our patients understand what we know. We live in it every day. So just giving them very basic information, giving them reassurance that, yes, this is a safe place to visit. Your information will be secure. It is private, just like it would be if we were sitting, you and I, together in an exam room. So I really see that as an education tool to increase awareness of our patients, and then access to what is available for telehealth services. And then I think we can never forget to close the loop and get their feedback. So how do you survey your patients afterwards? Because really, in the end, it's patient-centered outcomes that we are after. So how did they feel about their experience, and what can we do to continue to make it better?
So at let's say a systems level, when you're trying to set up telehealth, where do typically things go wrong?
I think where things go wrong would be probably, I would say, lack of clarity of expectations,
Hmm.
lack of training, not whether it's preparation of the technology or also just execution of the visit themselves. Sometimes lack of, and this goes along with training, but lack of even running through a few mock scenarios before the patient gets involved, just so all members feel very comfortable with it. I think that's one area where we see improvements. And then I think too many top-down directives can get in the way. I think if we of course have to meet safety measures, we have to meet regulatory requirements. But once those have been met, really pushing the care to the front line and asking, I know I've said this, but it's so key, asking them what's working, what's not, how can we remove barriers to make this work even better for you?
I see.
If we can't seamlessly incorporate it into our day, it likely won't be successful for either on the patient side or the clinician side.
You also talk about in telemedicine the role of the facilitator. How does the facilitator help the physician so both stay engaged? What do you
You
think?
know, I see the role of the facilitator as kind of like the bridge or the liaison between the patient and the caregiver, the
Okay.
clinician. So how do they make sure it's scheduled right in the physician's schedule? How do they make sure it works on the patient's end? And then bringing them two together at the right time in a convenient manner, and also kind of somewhat maybe being anticipatory of what the challenges could be for the patient type, the visit type that we're in, and then also any troubleshooting that goes along the way. So I really see them as that bridge between the technology, the patient, and the caregiver.
Let me ask you a loaded question. It is about the DEA causing the delays on the telemedicine prescription of controlled substances.
Mhm.
Where do you see that going, or what is like an ideal solution in that thing?
Yeah. And that's a difficult question. I don't know where I see that going is the honest answer. But
Okay.
what would be an ideal solution, I do believe, is I do think we will have to figure this out for sure
Mhm.
with the need when it comes for controlled substances, a lot of behavioral health disorders where those patients do access telehealth more quickly because it's a safer place to do that. So how do we best prescribe controlled substances in a way that we feel it meets regulatory measures, but also meets the needs of the patient? I think this is one of those areas where we have a lot of trepidation because we've been burnt in the past with controlled
Yeah.
substances, but
Mhm.
now we're almost at the point where I believe we're holding back effective care if we
Mhm.
cannot figure this out in a way that works.
How do you see that affecting physician engagement, this issue, this topic?
Yep. I think I believe if we can move this forward, I think it will increase physician engagement. I think
Mhm.
this is a that's a topic with controlled substance where many physicians feel maybe very nervous or they have some level of anxiety.
Mhm.
Am I prescribing, am I practicing in a way that not only provides good care, but keep me, myself, the doctor, the advanced practice professional out of trouble from a regulatory standpoint. So I think giving the reassurance that this is the mechanisms that are in place, we are in compliance as a health system. And as long as you are functioning within the guidelines of our organization, which meets the standards, we can reassure you that this is a safe, efficient way to practice.
Like right now, how far is the geographic reach of your telehealth?
Yeah, so our telehealth region, we are based out of Sioux Falls, South Dakota. Our core region is a 5-state region around Sioux Falls, South Dakota,
Mhm.
Nebraska, South Dakota, North Dakota, Iowa, and then
Mhm.
extending up into Minnesota.
Okay.
So that's our core region of our footprint. However, our telehealth services go out much farther than that into many of the surrounding states, kind of throughout the Midwest and extending down into the South, even into Texas.
As people who are listening to this or watching this, as you can see, that this can't be done without a doctor like Dr. Post sitting in a leadership position and not just guiding or doing things, but also visioning things and so they can actually happen. So, Dr. Post, if there's a young physician who's listening or watching this, what advice do you give them? Any all advice, I mean, is welcome. We talk about leadership, you teach about leadership, work is fair game, but what advice do you have for
Yeah,
a young doctor?
yeah, I think looking back as you move, if you do move into physician leadership, I think the key for me is to remember your roots. Like you can never forget where you came from and what it feels to sit like in that exam room or in the hospital room at the bedside with the patient. Because then as you make leadership decisions, you always have to remember, how is this going to impact? How would have it had impacted me in my day in that small town where I used to be? I think a danger of going into leadership is getting too far away from the front line. So
Mhm.
never losing the perspective that you had when you were at the front line and keeping the input of your colleagues who are at the front line is so key to making those decisions.
Do you recommend any books or resources that you would like a young doctor, aspiring, ambitious doctor to know?
Yep. There's some things you read and you're like, boy, I wish I would have known that 20 years ago.
Okay.
And one of them for me was the book named The Servant by James Hunter. But
Okay.
I think it really describes the mindset that is needed for all leaders. To be honest, it's not specific to healthcare, but especially for physician leaders, we are in such a service-oriented industry. And core at every physician's heart is patients and patient care. But I think as you move into physician leaderships, you get into a point where you are now a doctor for the doctors. You are taking care of your caregivers so they can deliver quality of care. But if you do not go into that with a kind of a servant heart and the humility that you're placing others in the organization above your own personal goals and your own career goals, I think it can be a danger. So that is one book, The Servant by James Hunter, that I would recommend.
So how long have you been in the field? Then, you talked about, oh, wish I had read this 20 years ago. If you could turn back time, what would you do differently and
Yeah.
why?
Yes, one thing I would definitely do differently is I would have kept more of an open mind of where I wanted my career to go.
Mm,
Early on as a physician, I was convinced I wanted to be a small town rural physician doing obstetrics, and that's exactly what I did. But I really kind of pigeonholed myself into that life, and it was only through some opportunities through our family medicine service line that we have in our organization, through our physician academy development program, that really opened my eyes that there is other ways to serve outside of direct patient care, but you never want to lose why you went into it. So there's a quote by Andy Stanley that I really like, and it's marry your mission, but date your model. So know
okay.
why you went into healthcare. Never lose sight of that, but there may be different ways that you go about fulfilling that. So today, I impact patient care much differently than I did when I started in 2005 as a rural physician. But to me, it's having an organization, it's having a culture where my colleagues can deliver effective care, because I truly believe if you do not have engaged physicians with a healthy well-being, you cannot deliver quality of care without physician engagement.
Marry the mission and date the model.
Yeah,
Wow, I never heard that
right.
before. So
Yeah.
how have you
Yeah.
applied that? Tell us about that.
Yeah, so that's difficult when you move from being a practicing physician. I did a lot of work in family medicine, also in the emergency room. I then transitioned to being a physician advisor part-time, where I helped physicians with clinical documentation, as well
Hmm.
as getting on patients on the right level of care, such as
Hmm.
observation versus acute care. It was through that I first started working with physicians in a role outside of direct patient care.
Hmm.
And so that was the first time I was like, okay, I am really enjoying this type of practice where I can help my colleagues deliver better care, deliver more accurate care, and do so in a way that it really came down to relationships, the ability to have critical conversations when needed, but in a respectful manner. And that's how I kind of got introduced into maybe more of this administrative world. And honestly, I fell in love with it. This was never my intent to be in
Hmm.
this leadership role. In fact, if you would have told me 5 years ago I would be doing this today, I would not have believed you. But it was just through that, I think, stepping into something outside of my comfort zone, that I realized that this is truly a way I want to give back to my colleagues so they can provide great care.
Well, it's kind of like, let's say if I were to ask you, what helped you take that first initial step? What was that?
Yep. I would say the first initial step was becoming engaged.
Mm,
Um, I had a partner who asked me if I'd be willing to serve on our primary care service line. And
hmm
that was my first engagement outside of clinical practice, and it really opened my eyes to how our organization works, but also the larger operations of healthcare in general. I would
hmm
say so. Stepping out of your comfort zone and being willing to do something different, exposing yourself to more colleagues, more of the administrative operational side to healthcare was really probably the first step. But the turning point for me was our internal physician development program, which is an
hmm
8 month curriculum. And that was really what made me maybe really looking deep inside of what do I want to do in this next phase of my career. And that was a lot of, emotional intelligence
hmm
testing, becoming much more aware of who you are as a person. What are your motives?
hmm
How do you focus on your strengths while being aware of your weaknesses and trying to improve them as well? And that was really the turning point of maybe asking myself, do I want to do something somewhat different as I progress through my career?
And now you do that. You're teaching others how to do that.
Right.
This is
Yeah.
so wonderful. Whose brainchild was that? The one that you took
Oh,
part in?
yeah, that was our who he is now retired, but his name was Fred Slunica, who was a chief operating officer at the time. And back in about 2010 to 2012 was when Avera started implementing physician-led service lines. So we
Hmm
now have 14 service lines throughout our
hmm
system, primary care, orthopedics, cardiology. But at the time, he had the vision to say, if we're going to ask physicians to be leaders, we need to educate them on physician leadership and what it means to be a physician leader. So
hmm
really our development academies, which we have our physician academy, and then we have one called a dyad academy, which is half physicians, half administrators, really
hmm
built out of the need, like if we are going to ask physicians to lead, we have to
hmm
give them the tools and the skill sets to lead with.
Very good. Wonderful, wonderful. I think that this is such a needed area. And obviously, right now, you're not just leading physicians, you're teaching them how to lead as well. This is wonderful. This has been such a nice interview. Wonderful talking to you. And I'm going to remember this one, marry the mission and date the model.
Right. Yes.
Very
Yeah.
good. So, well, that's all the time we have.
Okay.
Thank you, Dr. Post.
Yes. Thank
And
you.
yes, thank you for teaching us.
Okay.
Thank you for standardizing the terminology in telemedicine. I think we all should use this terminology instead of making up and then people not knowing what that person is talking about. For example, I think that for standardized billing for portal visits, it should be called a portal visit. So
Mm-hmm.
this is a huge contribution you have in our field
Yeah.
and helping with physician engagement. So thank you very much.
Well, thank you. I might have to tell Carson Dye if we do a second edition that he might have picked the wrong guy for the telemedicine chapter, but we'll see.
Thank you.